Equipment needed for intubation of a working canine includes endotracheal tubes, a laryngoscope with a working light, sterile lube, dry gauze squares to hold the patient's tongue, a syringe to inflate the cuff, and either intravenous tubing or roller gauze to tie the tube in place. Most working dogs will take between a size 9 to 10 cuffed endotracheal tube, which is usually the biggest size that's carried by medics. For canines, we use a straight or Miller blade when we're intubating them rather than a curved blade. So this is the blade that you would want to use to intubate a working canine. For intubation of conscious animals, heavy sedation or light anesthesia will be required. If you're intubating a debilitated or unconscious animal, no sedation is usually required. We preferentially intubate dogs in sternal recumbency. However, if you're performing CPR and chest compressions are already occurring, intubating in lateral recumbency may be necessary. In a patient who's breathing spontaneously, pre-oxygenation can be given via flow by oxygen. As with intravenous catheter placement, having a good assistant or holder is very important for the success of canine intubation. You want to start by having the assistant hold the animal's mouth open. They will take one hand and put their thumb and either their pointer or middle finger around the animal's muzzle on the top. Both fingers will be directly behind the maxillary canine teeth holding the top jaw. The assistant will then take their other hand with a dry gauze and use the gauze to hold the patient's tongue out of the mouth. When they pull the tongue out of the mouth, they want to pull it forward and down over the incisors. This allows the intubator to have a better view of the structures through which they're going to intubate. Once the assistant has the oral cavity held open, the intubator should use the laryngoscope with the straight blade and insert it into the oral cavity. The intubator should insert the laryngoscope until the tip is immediately in front of the epiglottis on top of the tongue. Gentle pressure should be applied to the top of the tongue to pull the epiglottis down to expose the glottis surrounded by the vocal folds. Once there's a good view of the glottis, the endotracheal tube, which should have sterile lube on the tip, should be inserted through the glottis in between the vocal folds. Before inserting the tube, it's important to measure for the appropriate length. This can be done by holding the tube on the outside of the dog's neck and measuring until the distal tip of the tube is at the patient's thoracic inlet. That's how far you want to advance your tube when you're intubating. Advance the endotracheal tube along midline until the adapter, the tube adapter, is immediately in front of the patient's incisors. Once you have your tube inserted to the desired length, it's very important to secure your tube. This can be done with either intravenous fluid line or a length of roller gauze. The tie should be tied around the tube, behind the pilot balloon, but in front of the adapter. Once tied around the tube, the roller gauze or your fluid line is then tied around the top of the patient's muzzle and secured in place. The tie should fall between the pilot balloon and the patient's maxillary canine teeth. Once you have your tube secured, it's important to blow up your cuff. This will provide a good seal for your endotracheal tube. Once your tube is tied in and your cuff is inflated, if your patient is not spontaneously ventilating, you should hook them up to an ambu bag or begin ventilation at this point. If they are spontaneously ventilating, you can continue to provide flow by oxygen to the end of the tube. Once you have your tube in place, there are several ways that you can confirm correct placement. The best way and the only definitive way to know that your tube is going into the correct place is to visualize the tube going through the vocal folds into the glottis. I can't emphasize this enough that that is the only definitive way to know that your tube is going into the right place. Other things you can do to confirm that your tube is in the right place include visualizing condensation coming through the tube when your patient exhales. You can palpate the neck. When you palpate the neck, if you're intubated in the trachea, you should only feel one firm tubular structure. If you've intubated into the esophagus, you will feel two firm structures next to each other. Other ways include auscultating the chest when someone gives a breath to see if you hear appropriate lung sounds. Additionally, you can visualize chest excursions when a breath is being given. If you use this method, when the breath is given, the abdomen should not become distended, but the chest should rise. And furthermore, you can use capnography and your waveforms to make sure that you're in the trachea. It's important to note that if you do use capnography as a method to confirm your tracheal intubation, if your patient has cardiac arrest, you will not obtain a waveform.